Good morning, everyone, and welcome again to our virtual thyroid program. And I'm incredibly excited this morning. We have an international guest speaker, Dr. Iain Nixon, who I'm extremely pleased to introduce. He is currently a head and neck surgeon at the NHS Lothian and an honorary clinical reader in Edinburgh University. Dr. Nixon's training has truly been international. He has trained in the UK in a surgical program there in a very traditional United Kingdom format. And then he went on to complete fellowship training at the famed internationally renowned Guy's and St. Thomas hospitals in London. He then ventured across the pond to New York, where he spent time at Memorial, not only on the head and neck service, but also he managed to complete a PhD. In 2018, he was awarded the NRS Career Fellowship, giving him a unique opportunity to carve out time in his career to pursue academic interests. And in addition to numerous speaking engagements, both in the UK, Europe, and in the US, he was awarded the Seesaw Medal from the Royal College of Surgeons of Edinburgh. Dr. Nixon will provide a really interesting and very surgically oriented, but nonetheless multidisciplinary historical perspective on the management of thyroid cancer and bring us right up to the present. And once we're done, I'm going to push him a little bit more in order to take him into take us into the future. That being said, I do want to encourage all of you to write in your questions. As always, we will do our best to get to those questions at the towards the end of the hour. And so anything that's pressing on your mind about any aspect of the management of thyroid cancer, or if you'd like to venture into the realm of politics and the separation of Scotland from the United Kingdom, I'm sure he'd be happy to wax on that as well. For those of you who were part of our first inaugural thyroid tumor board last week, I did mention at the end of that we will be conducting that every 2 months. And I'd like to encourage all of you as you broach questions or as you address head cancers in your own institutions that you think are interesting and would be of value to present. We encourage you to submit those and look forward to having the opportunity to work with you to put those in our Friday morning programs. And so with that, I'm going to turn over the program and allow Dr. Nixon to present here. Thank you very much.
Hi, good morning. My name's Iain Nixon, and I'm an ENT head and neck surgeon in Edinburgh. I work for the NHS and for the university here in Edinburgh. And it's an honour to be asked to come and speak about managing low-risk thyroid cancers. And really, I'm going to try and talk a little bit about the evolving management of differentiated thyroid cancer as I see it over the last 100 years or so. I think I'd like to put it into some kind of historical perspective and talk about the recent progress that we've seen and maybe future directions that we might see over the coming years. Whenever I give a talk like this, I start by saying that you should remember that really I don't think there's conclusive evidence in this field. And so everyone kind of comes to this argument with a bias. And I trained in New York with Sloan Kettering, who have a similar philosophy in some ways to the Mayo Clinic, in that with accurate risk stratification, they feel that there is a strong argument for conservative treatment of low-risk thyroid cancer. And as a result, I'm kind of biased in that direction. So when you listen, you should see my talk through that lens. Anyway, with that, put that to one side, and let's think about the distant past. Now here I'm talking maybe 100+ years ago, which was the era of the surgeon, because there was nobody else. Imaging hadn't been formalized with the thyroid. Fine needle aspiration wasn't a thing, and really it was the surgeon and the patient who were left to deal with the disease. And when they came from the golf course, they would recognize that some of their patients had potentially fatal outcomes. And it was unclear how you could avoid that, because surgery was extremely risky. The disease was unpredictable. Some lumps stayed unchanged for many years. Others rapidly grew and were fatal within weeks. And of course, preoperative imaging and biopsy, as I said, were not available at that time. And there was significant variability in practice. Some institutions didn't even allow thyroid surgery because it was thought to be so risky that the risks outweighed any potential benefit. And so that's really a very different era than the one we practice in today. And one of the first big recognitions was that histology could be used to predict outcome. And it was quickly shown that if you could demonstrate anaplastic histology, patients in that cohort rapidly died of disease, whereas patients with non-anaplastic or papillary cancer, as it would be known, did extremely well. Now, it's hard to imagine practicing in those conditions, but of course there were people like you and I who did this, and that was a great leap forward in the understanding of the biology of thyroid cancer. But if we now come forward in time to what I've called the past and the start of nuclear medicine, and we're going to come back to this again, but we get a lot to thank the US Air Force for. In the middle of the 1940s and into the 50s, there were a great deal of scientists with expertise in nuclear physics who found themselves without much to do, and some of them came into nuclear medicine and gave birth to that field of medicine. And there was a recognition that if you made iodine radioactive, you could demonstrate remarkable effects in patients with advanced, what's seemingly incurable thyroid cancers. And clinicians were able to give this and show regression of distant metastases, and they could actually see disease shrinking in front of their eyes. But really, it was at that extreme of the condition that it was used, and its role in managing lower risk patients was unclear. So again, this seems like a foreign time to us, because again, imaging wasn't advanced, but as we come closer and closer, we enter what I've called the era of endocrinology, and partly that's maybe the endocrinologist, Ernest Mazzaferri. So with the recognition of histology as a critical predictor of outcome, there's also the understanding that if you're going to look at papillary thyroid cancers, you're going to need a lot of them, because the event rate is very low. Very few people die. And so you need a large cohort of patients followed for a long time. And the US Air Force again offered this opportunity with they had a database of pathology and treatment and outcomes. And Mazzaferri looked at this in 576 patients. Now, this was a relatively stable cohort, relatively stable pathology reporting, relatively stable approach to surgery. So these are all good things for what is fundamentally a single institution study. And it generated this paper, which is quite a difficult read. I don't know if any of you actually sat down to try and read it, but it's extremely detailed. Has 22 pages of single line spaced text, 13 tables, over 100 references. And there are multiple findings within it, but some of the findings include the fact that patients treated with total thyroidectomy versus less, and radioactive iodine versus none, actually do better. And that really went on to shape an approach to managing thyroid cancer in the kind of Mazzaferri mold, particularly in the US, but indeed internationally. And if you look, for example, at table 10, and this is just lifted a screen grab from the paper, you can see here that I don't know if you can see so well, but there's a significant difference in recurrence. The survival difference is much less, but That's to be expected because death really is very uncommon, as we will come to see in papillary cancer. And indeed, when you look at the radioactive iodine figures, there's about a 6% improvement in recurrence rates. Now, this has been criticized. It's been criticized by many people. Probably some people listening to this talk are in print criticizing it. But one way or another, it became a very important paper. But it wasn't the last paper published on this subject, not by a long way. And many papers have analyzed this as the kind of era of big data started to arrive, and bigger data sets were available for analysis. Now, Bill Amoria did this for a whole bunch of cancers, but one of the cancers that he looked at was papillary thyroid. And he was able to show, using the National Cancer Database, that, again, there was a greater recurrence after thyroid lobectomy, and the survival was improved by being more aggressive surgically. And so, again, this seemed to reinforce what Mazzaferri had described 40 or 50 years earlier, that being more aggressive was beneficial for the oncological outcomes of patients. So really, this then translates into what has then been described as a one-size-fits-all approach, that it was very easy to decide what to do. All patients who had tumors that were 1 centimeter or greater had a total thyroidectomy and radioactive iodine. So really, there was no need to overthink it, and these patients did extremely well. I'm not talking about the central neck. We could cover that in the questions, but for all intents and purposes, you did your total thyroidectomy so patients could receive the radioactive iodine. Now, that Bill Amoria paper came at the time of the rise in international guidelines. There's now a huge number. UK have them, Europe have them, China have them, Japan have them. They're all over the world. There are international guidelines. Even Scotland, little Scotland has its own one. But I think probably the definitive version is the American Thyroid Association guidelines. A lot of effort put into reviewing the literature in this. And the Bill Amoria paper came out as this group were considering the wording of how to treat papillary thyroid cancer surgically. And it translated into the reinforcement of the Mazzaferri message that really total thyroidectomy and radioactive iodine was the standard of care for most patients with thyroid cancer. Fine, so that's good. Patients do well, it's very easy, anyone can do it, but why might this be a problem? Well, anyone who's done a thyroidectomy knows that there are complications. You cannot do a thyroidectomy and be a long way from the recurrent laryngeal nerve. If you injure it, a patient will be hoarse. If you injure both, they may need a tracheostomy. In addition, parathyroids are notoriously difficult to identify and challenging to try and spare. And if you damage them, patients develop temporary or permanent hypocalcemia. About 1 in 5 patients gets a temporary hypocalcemia following total thyroidectomy. Permanent hypocalcemia is less common and probably somewhere in the region of 1 to 5%, something like that, depending on your outcomes. And indeed, of course, if you do a total thyroidectomy, then a small group of patients never quite feel right again. They do need thyroid hormone. And that's inevitable if you do a total thyroidectomy. And you can tell that there must be a lower rate of injury if you do half a thyroid rather than a total thyroid, surely. Well, maybe not. Now, I'm going to use this as an example. There are many. I use this because the first author, Orlo Clark, is American. I thought you would recognize the terminology. He reported this paper, 160 total thyroidectomies. And in those 160, he did not injure a single recurrent laryngeal nerve. So 160 totals, was that 320 nerves at risk. He had to sacrifice 3 at 1% sacrifice rate. Probably, given his name, the more aggressive cases are being sent his way. In addition, one patient ended up hypocalcemic, and that was a patient with widespread nodal metastasis. And anyone who's done particularly extensive central neck dissection will know that those patients, their calcium drops, and your fingers crossed they come back, but they don't always. And so, that's fairly compelling evidence that you can do a total thyroidectomy very safely. But let's take a moment. Now, I've never met Professor Clark. He was Emeritus Professor of Endocrine Surgery at UCSF. He graduated from med school at Cornell in the 60s. and residency at UCSF. Of course, came to really learn how to do it properly in London in the Hammersmith Hospital. We will take credit for him. But then went back to practice in the States and went on to become president of the American Association of Endocrine Surgeons, the American Thyroid Association, and the International Association of Endocrine Surgeons. So, I mean, I've truncated his resume, but you would look at that and say that's fairly exceptional. Not many people rise to that level within their specialty. Now, I can run 100 meters, but if I tell you that I could run as fast as this guy, and I think you're lucky enough never to have met me, but certainly I'm not looking at a sub-10 time. And I think comparing ourselves to Orlo Clark is probably unrealistic. If you look at more real-world data, and you know, I'm going to do this thing in this talk of criticizing international databases when they don't say what I want, and then commending them when they do, but bear with me. This looked at 14,000 patients treated in Italy, almost 15,000. And I don't think it is that difficult to get your head around the concept that if you look at complications, if you do 2 sides rather than 1, you relatively double your complication rate. So in this group found that nerve injury following total thyroidectomy was present in 4%, whereas following a lobectomy was present in 2%. Hypocalcemia, of course, doesn't happen with lobectomy, almost 0, and but of course it does after total thyroidectomy, and in this series, a 2.2% risk of permanent hypocalcemia. If we look at some US data, and this really was done to demonstrate that high volume surgeons had better outcomes than low volume surgeons, which I think is another thing we would probably agree with. But it's very interesting to see that the rate of complication almost doubles. So if you take the low risks, 11 to 24%, 9 to 18, 7 to 14, you know, there's almost exactly double the number of complications if you do bilateral surgery rather than unilateral surgery. And okay, I think it would be fair to criticize the question about why did 7% of lobectomies become hypocalcemic? That suggests there's a problem with this data somewhere. But nonetheless, I think it chimes with what we know about surgery, that you can't do surgery without complications. So obviously in the UK, we have a long history of audits, and the British Association of Endocrine and Thyroid Surgeons effectively produces a national audit report. Now, I might think of this as my benchmark in the UK, and it's a series of dreaded funnel plots. And I don't know if you're familiar with these funnel plots. They've become a big thing in UK benchmarking. But what they do is, this is looking at the rate of late hypocalcemia against the number of operations. And you would expect the more operations you do, maybe the better you are, and the lower your numbers. And there's, maybe there is that trend. And you can see the average rate of late hypocalcemia, defined as patients on calcium at 6 months, was greater than 10% in the UK. And some people have a much, much higher rate. This is after first-time total thyroidectomy. You know, some of these surgeons have got more than a third of their patients end up permanently hypocalcemic. Now, you can point to criticisms in this data too. It's provided by the surgeons themselves, but you know, there are weaknesses in it. One of the big questions is, how often do you damage a recurrent laryngeal nerve? And when the UK looked at it, you look at this funnel plot, and it just doesn't make sense, really. There's such a wide distribution, and this is largely because so many people don't look at the vocal cords after they treat patients with thyroidectomy. And so indeed there was really couldn't extrapolate anything from this data. And when the association looked at recurrent laryngeal palsy rates, they found that if you look at less than a third of your patients, you have a recurrent palsy rate of less than 2%. That's pretty good. If you look at more than 80%, you've got a rate of, 4.2%. And the strongest predictor of injury was looking. So you would think, it may not be fair to say this, but you would think that the people who are looking very carefully, well, either they're, damaging a lot of nerves, they feel they want to look, but it feels more likely to me that they're slightly more fastidious about things like data collection Whether that translates to nerve palsy rate, I don't know, but I would put to you that probably nerve injury rate is closer to the 4 or 5% rather than 1 or 2%. So put that to one side for a second, and this is data from MSK actually, but it's just figurative as much as anything. That really there was a widespread, a wide variation in practice between total and hemithyroidectomy up till about the 1970s, and then as the Mazaferi data comes out, and increasingly there's a consensus behind total thyroidectomy, the rates of total thyroidectomy rise and rise, and lobectomy fall and fall. So not all groups agreed that this was the correct approach. Of course, the Mayo Clinic are pivotal in this. Sloan Kettering like to think of themselves as well, but there are other groups, South America and further afield, that felt that the data presented was not that compelling. And when you think about the arguments against what Mazaferi put forward, really his data predated risk stratification. He did use size, as I mentioned. But we would come to recognize with the MACIS that the risk stratification is critical in planning treatment for thyroid cancer. In addition, the data dates back to the late 30s and 40s, and it reported on Air Force surgeons who use versus what we might call trained endocrine surgeons, like I'm sure many people in the room now consider themselves, who it's likely are doing a different job than the Air Force surgeons who were doing the best job they could at the time. But one would hope that standards of training have improved over the last 80 years. In addition, of course, and this is a weakness of all thyroid studies, the diagnostics and follow-up are outdated in comparison to what we do today. So if we look at the Bilimoria type data, that was drawn from national databases, and it lacked important clinical details on things like extrathyroid extension and completeness of resection, which, as I say, from MACIS we know is critical. And it has been criticized for that. And indeed, the database itself has improved to include these. And as it has improved, the significance of the aggressiveness of approach to treatment has been lost, suggesting when this was updated, I think by Sosa, that significance was lost, suggesting that now, with improved data, we can see that the argument that total thyroidectomy and radioactive iodine are better than hemithyroidectomy alone are lost in the low-risk group. So I've touched on this already, but risk stratification in differentiated thyroid cancer can be done easily and reliably based on age and based on tumor factors, size, metastatic thyroid extension, and completeness of resection. And indeed, you can also stratify patients into the risk of recurrence. Now, this is more relevant, I would say, that because so few people die. If you just say to patients, you're not going to die of thyroid cancer, you'll be right 99% of the time in papillary. That's pretty good. You're not going to get a system that predicts much better than that. But recurrence is what patients worry about. And if you can, there's a whole host of factors, completeness of resection, nodal metastasis, and histological features, which allow you to predict the chance of recurrence. So everyone's got their own system, obviously the Mayo Clinic and the lay group. There's so many different groups, but they're all much the same. Completeness of resection, extracapsular invasion, age. People have used other things, grading, DNA, ploidy, but it all comes down to the same thing. With some simple preoperative factors, you can predict the risk of recurrence and or death. And when you plot these, and this is using the memorial figures, you can see that patients who are lower intermediate risk, they really don't die of disease. Even high-risk patients die relatively infrequently. Looking at these are 5-year figures, but a 10-year graph. And of course, the pivotal paper comes out in 1987, looking at ipsilateral lobectomy versus bilateral lobar resection in papillary thyroid cancer by the group, some of whom may be present today, and shows that in low-risk patients, there was no improvement from no improvement in survival from total thyroidectomy. And there's a number of different papers. This is the memorial one, and So these experts provided what you might consider an alternative view to the standard of care, which was total thyroidectomy and radioactive iodine for all. They argued that with proper risk stratification, low-risk patients derive no benefit from more aggressive treatment. Fine. So that's the aggressive versus the conservative approach for low-risk patients. So if we come back to what does that mean then? Well, what it meant was they would argue that total thyroidectomy versus lobectomy, that total had little to offer, that elective nodal surgery had little to offer, and that radioactive iodine had little to offer. So what does this mean in real life? Well, let's just take an average man, roughly 55 years old, and he gets on a plane and he's been diagnosed with anistic 1.1 centimeter papillary thyroid cancer, and he flies to France. Now, when he gets to France, they may offer him total thyroidectomy and bilateral lateral neck dissections. You know, I think they're slightly less aggressive now than they were maybe 5 or 10 years ago. But at the Institut Gustave Roussy, you know, a very famous cancer institute, that was the general approach to low-risk cancers, was aggressive surgery, followed by radioactive iodine. If you went to the United Kingdom, most places would recommend total thyroidectomy, at least. And in some places in the US, they may offer him isthmusectomy alone. If he went to Japan, there are some units who might offer him no surgery and active surveillance. And so in practice, there's a huge spectrum of approaches being practiced across the world for low-risk disease, from doing nothing. Of course, in the Mayo, you've looked at RF ablation and ethanol ablation for these types of things, through less than total thyroidectomy to total thyroidectomy to total thyroidectomy and neck dissection. So there's a very wide range depending on which airport you get off at. Okay, so but we say as I said at the start, does it really matter? Because these patients have excellent outcomes. But in practice, if we're going to say that we're willing to accept a doubling in rate of complications, that doesn't matter if the disease is super rare. But of course, we've seen an explosion in incidence over the last few decades. And of course, we see this explosion of incidence and no change in death rate from thyroid cancer, suggesting that there's an element of over-treatment. And if you're not only over-treating patients, and by that I mean that treating lesions that might never have caused a problem, but you're actually over-treating the lesions themselves with total versus hemi, well, suddenly you're looking at an epidemic of overtreatment in this low-risk group. So the status quo, as we left it, the 2009 guidelines, was in almost all circumstances total thyroidectomy. I didn't mention it, but elective neck dissection should be considered with the wording, and radioactive iodine to follow up. But the consequence of that aggressive approach was high rate of nerve palsy, significant rate of hypothyroidism, and then the side effects of radioactive iodine, which are not none: dry mouth, difficulty swallowing, impacting quality of life, and you know, at a population level, second primary malignancies. A lot made of that, but it's pretty rare. So what went wrong with the message? Why did these guys, who were largely men, who struggled to get their message across? It's difficult to know, is the bottom line, because it seems so obvious. But maybe it's because in practice survival didn't matter. So they produced a number of staging systems which are largely targeted at predicting survival. That meant that staging had little impact on selection of treatment, because if you come back to the kind of amalgamation of all these different staging systems into the AJCC staging system, if you're under 55, as long as you don't have distant metastasis, you are considered stage 1. However, you could have a large primary with significant nodal disease and nobody would treat you with anything less than total thyroidectomy and radioactive iodine, even though you're stage 1. Whereas if you're 56 and you've got a 3 centimeter papillary, which is unifocal with no nodes, you're stage 2, and hemithyroidectomy seems reasonable for that. So there is this kind of disconnect between staging and treatment. And again, in addition, advances in histology have muddied the water. It used to be very simple. You had a papillary, you had a follicular. Now there's all different kind of variants. There's tall cells, there's lymphovascular evasion. There's all sorts of things which are difficult to interpret, which make it more difficult to decide. But if we look at, we come back to this concept that the outcomes are fabulous for these patients, even the high-risk ones do well. That really, I think the general approach to managing thyroid cancer is to surgically excise all cervical disease that you can see, and then prepare a patient for radioactive iodine. And I mean by that, doing a total thyroidectomy if they have distant metastasis, or if for some reason you think that there's a high chance of occult disease that might present later. And that's not probably for locally invasive disease, but you basically think you might have left microscopic cells behind that may be iodine avid, or patients who were N1 at the start. And that, most patients are N1. You just can't see it. But if they're clinically N1, I think the common sense or the consensus, perhaps would be a better term, is that there's a phenotype of disease that will tend to manifest, whereas tiny little irrelevant nodes never manifest, so there's no point treating them. So this is the AJCC staging system as it stands, and as I say, there is this problem that there is a disconnect between staging and treatment, which makes it difficult to know where to use it. But you see, you've got these early stage that you could be under 55 with N1B disease and still be in stage 1. And that's very different from a T1N0 micropapillary carcinoma in an older patient. And the treatments are very different, even though the staging is the same. So I think this is a useful figure from the ATA guideline. They popularized the low, intermediate, and high risk staging system for recurrence. And they show that on the left. But then they give more specific details on the right about individual risk factors that influence the risk of recurrence. So the spectrum extends from unifocal papillary cancers, which have an extremely low risk of recurrence, up through patients with nodal disease, right up to patients with gross extrathyroid extension and extensive vascular invasion. And I think that spectrum is useful. I mean, it's probably not 100% accurate, but it gives you a kind of toolkit to think about what recurrence risk you're willing to discuss with the patient. So these are, I think that's a useful thing to keep in your mind. Okay, so that's where we were. We're recommending total thyroidectomy and radioactive iodine for most patients, but not everyone agrees. And we come to a more contemporary period. For some reason, I've called it the era of the health insurer. But I obviously was spending a lot of money on health, and but what happens is this: on the left is the British Thyroid Association, butterfly, and on the right, of course, the American Thyroid Association. And what we see in the last 5 or 6 years is a softening of the approach from both of these societies, accepting that total thyroidectomy may not be required in all patients. The problem with their statements is they become, having been fairly definitive and making it easy to decide what to do, they introduce this concept of individual choice or personalization of care. And obviously, personalized medicine or individualized medicine is a kind of buzzword at the moment. But they suggest a kind of balanced approach. So if you've got an older patient with large volume tumor, extrathyroid extension, and particularly if you're a clinician with low complication rates, they recommend being more aggressive. Whereas if you've got a younger patient, particularly a professional voice user, although who isn't a professional voice user these days, if you've got small volume disease and you lack all these high risk features, and if you've got a higher complication rate, and really, the clinician should understand this about themselves, to be honest, then a less aggressive approach is recommended. So now we have the overall approach to thyroid cancer. You take the patient, and indeed maybe I should say the patient and the clinician, and you stratify them, lowest, intermediate, or highest risk group. And low risk patients, they have little to benefit from thyroid lobectomy, as we've been being told since the middle of the 1980s. The highest risk patients still need to go for radioactive iodine, and then there's a large intermediate risk group that could go either way. Now, the progress is slow in terms of changing the guidelines, because despite all the evidence, the British Thyroid Association words it this way: the evidence for an advantage of total thyroidectomy compared to hemithyroidectomy in patients with unifocal tumours between 1 and 4 centimetres, age under 45, with no extrathyroid extension, no familial disease, and no evidence of lymph node involvement, no angioabrasion, and no distant metastases is unclear. So more or less, they say, if you have a small tumour and you tick every single low-risk box, then it's unclear whether being more aggressive is worthwhile. Rather than what I might have preferred to see, which was, unless you have one of these high-risk features, then the advantage of total thyroidectomy is unclear. Nonetheless, it is a softening of approach. However, if you take that and then put it into real-life practice in Edinburgh, you'll find that half of our patients are over 45, so they're ineligible. A third of them have multifocal disease. A quarter of them have local invasion. Almost 1 in 5 have nodal disease, and occasionally we see perineural invasion. So when you take all of those out, you're left with only 8% of patients who are potential candidates for conservative management, because it's worded in such a way to make the real-life selection of patients for conservative treatment very challenging. So where do we go from here then? Are we returning back to the era of the surgeon? Well, what's changing? I think we're moving away from the concept that the patients with papillary cancer can be cured. We certainly now understand that patients with papillary cancer have a high rate of nodal disease, and just because you don't take it out doesn't mean that it will manifest. So they're not really cured as such, because there's still papillary cancer in them. Even if you do a total thyroidectomy and neck dissection, you're likely to leave some tiny cells behind, but you don't necessarily need to treat it. We also recognize now that some small cancers constitute less of a risk to, some small cancers are less risky to patients than their surgeons. And I think the Japanese groups have shown this well, that an approach of active observation might be perfectly reasonable in some small cancers. The limits at the moment 1, it may well go up to 2, who knows, maybe further than that. You've also got this option, as shown by the Mayo, of doing a kind of RF ablation type of approach. I think that's also potentially useful in the lowest risk cases. We know that there's this high rate of microscopic disease in nodes that never manifests, and if it does, it can almost always be salvaged. I think this the audience is probably involved in managing squamous cell carcinoma. Now, if we compare this in patients who recur with squamous cell carcinoma in the neck, it's almost always a death sentence. And as a result, clinicians who deal with both, I think there's a tendency to really fear regional recurrence. But if you look at the literature surrounding success rates of regional salvage, they're extremely good. But I think there's also now a recognition that treatment intensification in highest risk patients is beneficial. So those patients with the most aggressive type of disease do benefit from being more aggressive. So I think where we are now then is we take our lowest risk patients, some of them may go for observation or thyroid lobectomy. The intermediate risk group are either lobectomies or surgery with radioactive iodine. And in the very highest risk groups, we might even think about extended treatment, surgery, iodine, occasional external beam, or targeted therapies in those with the most advanced unresectable disease. So really, this is the same. The lowest risk group where you're going to observe or at worst do a lobectomy, But in these highest risk groups, and this is the group with gross extrathyroid extension, nodal disease, distant metastasis, but this isn't really the focus of today's talk. But the difficulty, I think, is that now the way the guidelines are worded, almost all patients fall into this. I think it's said that something like 85% of patients who present fall into the low risk MESAs group. And when you look at that, most patients, you've got this personalized decision making to do, and it's quite difficult to balance risk and benefit. So how do we do it, and what's changing in terms of the evidence? Well, we're now starting to see that probably radioactive iodine only benefits the highest risk group. There's a number of studies now which are randomized controlled prospective trials from Europe, the Seesaw Model trial, high-low, and soon the ION trial, that have looked at either high dose versus low dose radioactive iodine, and now low dose versus no dose in these low and what would otherwise be called intermediate risk groups. It's likely that they're not going to show any difference between the two approaches, although the no dose studies are yet to be published. And there's a recognition also that these pathological findings in the absence of clinical findings, and I mean, for example, extrathyroid extension reported on a microscopic basis, which isn't evident in the operating room, are of minimal significance. And that's flowing now into the AJCC staging system and the ATA risk stratification. And I feel like it's likely that as the radioactive iodine message comes through from these prospective trials, surgery is likely to be the main or only treatment modality for the majority of patients who present with papillary thyroid cancer. Now, we are seeing this in Scotland. There are very few groups in the UK who have enough data to present their findings. This guy, Zik Rogowski, had a long career in a regional centre and used the MESA system to stratify his patients and only gave high-risk patients radioactive iodine, did lobectomy for the rest, and as you might expect, 99% are alive 20 years later. Yeah, so as I say, this is aimed in some ways at a Scottish audience, but yeah, rates of recurrence, and death are tiny. I think it's well recognised that MESA doesn't just work in Rochester, but does work internationally. But it's been very interesting. This paper has not been well received in the UK. Even though excellent outcomes are shown and easy with an easy staging system to apply, but residents who are listening to this will find when they graduate it will seem obvious, and they will then go and join teams around the country, maybe around the world, who have practice patterns and saying to pathologists suddenly, well, I know you're reporting microscopic extrathyroid extension, but it doesn't matter, when for years it's been the critical thing that pushed patients into more surgery. Pathologists don't like it, endocrinologists don't like it, and nuclear medicine physicians don't like to be told that they don't need to give radioactive iodine. And so there are huge barriers to convincing a wider disease management team outside of a centre that's popularized this approach to a less aggressive approach to treatment. So I'm going to start to wind up and just say that what I hope I've shown is that over the last century, there's been a standardization of practice based on histology and clinical features that are related to oncological outcomes. In general, we've placed more emphasis on oncological outcomes than complications. Now, I don't know why that is. Maybe because surgeons don't like to own up to their complications, maybe because it's difficult to collect them. They're not immediate complications. You need to relook at 6 months, and that's difficult to do. But one way or another, the focus has been on oncological outcomes. And in practice, there's quite a lot of literature saying that that's what patients want, not necessarily in thyroid, but in other diseases, that they will give anything to get a better oncological outcome. But the original data that suggested outcomes were better with more aggressive treatment has kind of been undermined. So it's not necessarily beneficial for them anymore. We have an understanding of biology that's improved significantly. We talked about histology, but I think the improvements in our understanding, the improvements in access to imaging have led to an improved appreciation of risk stratification, and it's critical. I'm sure you all will be familiar with risk stratification when you graduate from your program here. But I think we also are developing an improved understanding of complications, and that bilateral surgery is associated with roughly a doubling of risk of complications. And that improved overall understanding allows us the opportunity to improve overall outcomes without compromising oncological ones. So in conclusion then, an improvement in our understanding of disease biology for low-risk differentiated thyroid cancers allows surgeons to offer conservative therapeutic approaches which maintain oncological outcomes while optimizing functional ones. And I'll leave it there and we'll move to any questions.
Iain, thank you very much for really an outstanding talk. I feel like we've covered the last century of clinical thyroidology in 45 minutes here, in a really very in a wonderful and very poignant presentation here. I think you've highlighted really one of the unique features of thyroid cancer management, which Orlo Clark had commented on in one of his presidential addresses, how unique the thyroid is in the scope of oncologic surgical management or oncologic management in general, with such this just incredible array of low risk and often incredibly high risk disease manifesting in one simple organ. I think your comments about many head and neck surgeons having to balance their mindset between the management of low and intermediate risk thyroid cancer against our management of squamous cell cancer, and how that becomes extremely challenging. And the other incredibly important thing is a recognition that complications have to drive surgical decision making. One of the questions from our audience has to do with your thoughts related to the role of molecular testing in the management of differentiated thyroid cancer. I'm not sure if it's as readily available in the United Kingdom as it is here in the US. Perhaps you can talk about that with an eye towards how that affects your own thoughts in the management of individual patients with this disease.
Sure. So you're right to say that in comparison to the US, molecular testing hasn't taken off so much in the UK. So it's not part of my routine practice, although there are two areas that you might apply it. One might be molecular testing of biopsy samples, with the aim of determining whether or not surgical intervention is required in the indeterminate nodule. Now, we don't really do that at all, and I think there's been quite, the evidence from the funded trials has suggested that has very high accuracy rates. More independent trials have suggested the accuracy rates are lower, and it's dependent to some degree on the population that you apply it to. Now, we don't use that very much in the UK, but what we are starting to do is have molecular testing of the primary specimens. So in particular for BRAF mutations, and it's starting to creep into the discussion at the MDT. Now, I don't see that it has very much of a role. I think we recognize that BRAF mutation is associated with a slightly more aggressive phenotype of disease, but to extrapolate that to say that if you have an otherwise low-risk patient, that the presence of a BRAF mutation requires some kind of treatment intensification, I don't really think there's evidence there to support that approach. So we're starting to do it. The government in the UK has shown some interest in molecular testing across tumor types and thyroid pathology. We're interested to be involved, but I don't see that it outweighs the simple, trusted features of size, nodes, extracapsular extension, distant metastases, and age, which are the critical risk factors. So it'll be interesting to see if it does find its way into international staging systems, but I don't think it's quite there yet.
Great. What is the appetite in the United Kingdom for embracing active surveillance for low-risk thyroid cancers? And what's
Right,
your
that's
own philosophy?
a good topical question. So I happen to be part of the panel that are making recommendations for the upcoming British guidelines. And our impression is that, I mean, clearly there's a lot of good evidence out of the US and Japan in particular, that if you don't do anything to these tumors, that they don't progress in 2/3 of cases, particularly in older patients. However, if you're really critical of the literature, there's very little randomized trial evidence. A lot of these patients, presumably, I mean, the authors don't say, but they self-select into these groups. And you have to be quite selective within the groups in terms of there are factors like where exactly the tumor is within the gland, how close it is to the nerve and airway, and its relationship with the airway. And so it isn't widely practiced in the UK. We do practice it for patients who are not thought to be terribly fit for surgery. But the upcoming UK guidelines are not going to support it as a mainstream mainstream recommendation, but are going to suggest that it's an area for research. And in the UK, we have looked in a randomized setting at high versus low dose versus no dose RAI, yet to be reported, and about to look at hemi versus total thyroidectomy. And I think that the obvious extension of that will be to go to active surveillance as our next step. So fundamentally, we're not doing it very much in the UK, although I'd have to accept that there's many patient years of evidence in the right hands that it's a very safe way of doing it.
Great. I would assume that you embrace this new concept of staged thyroidectomy approach with an eye towards understanding the biology of the tumor and accepting the fact that that information may drive the decision to perform a completion thyroidectomy rather than doing that necessarily with at the outset of clinical decision making or surgical decision making.
Yeah, I think that this is something that I didn't appreciate so much until I left the States. When I worked in Memorial, you needed a cancer diagnosis to get through the door. So it was quite easy to make sweeping statements about how you can make decisions for patients before you operate. But for most people, when they are not in an institution like that, a lot of their practice will be diagnostic. So they'll have indeterminate needle biopsies. I mean, this comes back to the molecular question to some degree. But the surgery will be done not only for therapeutic, but for diagnostic purposes. Yet if you read the American Thyroid Association guidelines, there's no mention of completion thyroidectomy. And it feels to me that if you don't know what you're dealing with, if you're not certain, then it's fairly rare that you go into a procedure where you might do a hemi or total. So you're really talking about a patient without nodal disease. It's rare in my hands that I go into that with a discrete diagnosis of papillary cancer. Most of those I have a suspicion or they're indeterminate. And I would agree that by doing the initial hemithyroidectomy, you get a lot more refined information from your pathologist that you can then use to tailor the treatment. But you have to remember that two hemithyroidectomies, in my mind, is a slightly more, it involves slightly more discomfort for the patient, 2 anesthetics, more time off work. And I think when you're talking about a very fine balance of risk and benefit, you also have to consider that it's a staged completion is not the same as an upfront total, and probably should be reserved for slightly more aggressive tumors. But
so on that note, perhaps if you could discuss what your own philosophy is with respect to intraoperative decision making in the patient who by all accounts appears to have a low risk cancer. What intraoperative findings would drive your decision to perform a total thyroidectomy in that setting?
okay, well, certainly if you were to find features that suggested that total thyroidectomy might benefit, so gross extrathyroid extension would be a good example. But I'd have to say, I read the papers from the 80s and 90s, which presumably predated high resolution ultrasound and the excellent CT scans we have. And in my experience, it's quite rare that you find, for example, I've never found gross nodal disease that I'm certain about. In the UK, we're a little limited that our pathologists are not keen on frozen section, so it's difficult to confirm findings from the operating room, where it is in New York, we use frozen section more or less routinely. But and so the one thing I have found 2 or 3 times in my career is that I do a hemithyroidectomy for maybe an indeterminate nodule, or certainly not thought to be high risk cancer. And on the posterior aspect of the thyroid, which is a difficult area for ultrasound to assess, there is gross invasion of the nerve. And that's happened to me. Twice. And what I've actually done is just done the lobectomy that I consented the patient for, assessed the nerve, and then at a later stage gone back. And the reason I've done that is that, in my opinion, the risk in my hands, I guesstimate, of needing a tracheotomy following total thyroidectomy is about 1 in 1,000 to 1 in 10,000. Maybe less, because I actually use a nerve monitor and I would bail if the nerve monitor didn't give me a signal. But if I'm going to resect the tumor in order to get a clear margin, then on the contralateral side, I think then there's about a 1 in 100 chance, and I feel that changes the consent discussion. So I've done that 2 or 3 times in my career, but each time I've actually gone back and done the other side as a delayed, because those are patients who I think do benefit from radioactive iodine.
Great. Dr. Sugatani from Japan has raised the question of whether you feel that you can extend the indications of performing a lobectomy for patients with intermediate risk. And then there's a follow-on question to that that I'll wait for you to just reply to that.
Okay. Yeah, I think it depends on how one determines intermediate risk. This is when we looked at setting up a randomized trial. Getting people to agree what is low, intermediate, and high risk is difficult. I mean, for the individual patient, it's always very obvious what's low risk and what's high risk. But when you start to write down the criteria and you say, well, what does vascular invasion mean? Do you have to have more than less than 4 foci? Extrathyroid extension, is that low or high? So it's rather dependent on what you categorize as an intermediate risk patient. But I think that what we've seen with the move in the 8th staging system, particularly if you take extrathyroid extension, removing microscopic alone from the upstaging of disease, means that an increasing number of patients that would otherwise have been thought intermediate risk are now being recognized as lower risk, and as a result are being offered a less aggressive approach to treatment. And I'm hoping that we're going to try to switch the UK guidelines, as I mentioned in the talk, from being you should do a total thyroidectomy unless you meet all these criteria, to being the other way around, that you should probably do a hemithyroidectomy unless there's a high risk feature encountered either intraoperatively or on post-op pathology. So I do think an increasing number of intermediate risk patients will be considered for less aggressive surgery.
Great. So can you just comment again? This is a question posed by Dr. Sugatani. How do you think about the validity of dynamic risk stratification for patients who underwent lobectomy? Can you comment on how you follow them, how you're able to gauge the intensity of follow-up, et cetera?
Sure. Well, I mean, the dynamic risk stratification for people who are, I'm sure Dr. Sugatani knows about it, but for the wider audience, you take a patient traditionally treated with total thyroidectomy, radioactive iodine, and you do ideally a stimulated and unstimulated thyroglobulin, an ultrasound and a clinical examination, and then you can stratify them into those who've had an excellent response, an indeterminate response, or an incomplete response if you still see disease there. The problem with that approach is, of course, they have a thyroid lobe in situ if you've only done a thyroid lobectomy. And I think now there's pretty compelling evidence that thyroglobulin is not much use. You can have a recurrence without a change in thyroglobulin, and you can have a change in thyroglobulin without a recurrence. So it's a real problem. These patients are clearly low risk. And I was thinking about this as I walked back from work today, that I also manage squamous cell carcinoma, and I discharge people at 5 years, which is the UK practice, even though I know that they're at much higher risk of developing another squamous carcinoma of the upper air digestive tract or lung and dying of it Yet we in the UK don't have a clear route to discharge for these people following low risk thyroid management. And I think again we're working toward being able to. I think Mike Tuttle's work in dynamic risk stratification for total thyroidectomies is less useful in the lobectomy group. And I think really, if you're going to do a lobectomy group, a lobectomy on a patient, we should be accepting they are low risk and should be managed and followed as low risk. And I think internationally we have to find some route to discharge for these patients after a number of years. Otherwise, we'll drown under the number of patients that are being followed for thyroid cancer.
Great. Well, Iain, I want to thank you on behalf of all of our listeners. This was a wonderful discussion. We are right up against the 9 o'clock hour. I'd like to invite all of our participants to join us again next week. We will be discussing issues related to the role of central compartment lymph node dissection in the face of lateral compartment dissection or lateral compartment nodal involvement. And hope that you'll join us. Dr. Nixon, again, thank you for your efforts here and hope everybody stays safe and enjoy the weekend. Thanks very much.